We can go ahead. Thanks for joining a review of the Healthcare Analytics Adoption Model webinar. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded and will be available to you for future viewing. Throughout the session, all attendees will be in listen-only mode. So if you have any questions, please type them into the questions section on your GoToWebinar console. At the end of the presentation, we'll have a Q&A session with Dale, and we'll get to as many questions as we can. But if for any reason we can't get to your question, we'll be happy to follow up with you after the presentation. We like to keep things interactive, so throughout the webinar, we'll be launching poll questions for you to answer. Today, we have our Chief Strategy Officer here at IMO, Dale Sanders. And so as mentioned before, if you have any questions or comments while our presenter is speaking, please type them into the questions section. And with all of this being said, I would like to pass it over to Dale.
All right. Hi, friends. Thanks. Looking forward to sharing some thoughts with you here and also some feedback about this model. I'm broadcasting from our house in Cottonwood Heights, Utah, and our 5-year-old son is running around, so no telling what might happen during the broadcast here, but hopefully it'll all be fun. There I am. I want to acknowledge the development of this model has been ongoing for many years, more or less in order of acknowledgement and thanks here. My former colleagues at the advisory board, Meg Aronow, Ernie Hood, Mike Davis, Dennis Proddy, a dear friend and mentor of mine from the University of British Columbia, Victoria, Richard Gibson, now at Comagent Health, Tom Burton at Health Catalyst, Amanda Flanders at Health Catalyst. And I also want to mention that in the model, there's a reference to the data operating system, which I think now is copyrighted by Health Catalyst. It's essentially synonymous with an enterprise data warehouse or data lake. All right, bottom line up front, I wanted to review the model, let you put this in the back of your mind as we are progressing through the discussion today. My model has 8 levels in it, 9 if you count 0. And it starts at fragmented point solutions. Those are fragmented data solutions. At level 1 is the implementation of a data warehouse and enterprise data operating system in Health Catalyst vernacular. Level 2 is standardized vocabulary in patient registries. Level 3 and 4 is automated internal and external reporting. These are basically the commodity reports required to keep the organization running and also for seeking reimbursement. Level 5 is where differentiation starts to emerge in organizations as they reduce waste and care variability. Population health starts at level 6 with predictive analytics. Level 7 becomes more personalized with very prescriptive analytics on an individual patient basis. And then finally at level 8 is direct-to-patient analytics and AI. So I'd like everybody to kind of think about these for just a minute. I'll talk through some of the content on the right-hand side. I'm going to ask everyone in the next poll, in the next slide, to reflect on where your organization consistently operates in this model. While you're thinking about that, let's talk about the right-hand side for just a minute. So at level 0, you're tolerating inefficient, inconsistent versions of the truth, cumbersome internal and external reporting. At level 1 now, you've started to collect and integrate core data content. You're building out the content and the infrastructure to support higher order analytics. On top of that infrastructure and content is the curation, the organization, the standardization of data. Vocabulary is super important at this level. And reusability of data models and analytics logic is balanced with late binding. There's an efficient, consistent production of basic reports at level 3. Those are internal reports for the most part. At level 4, you've achieved efficiency and consistency of reporting for external things, such as compliance or accreditation and reimbursement. Level 5 is when you start reducing variability in care processes and you're focusing on the reduction and elimination of low-value care and adverse events. Level 6 using predictive models and suggestive analytics to support risk intervention. Risk reduction models are informed by economic models that reward prevention over treatment. So that's an implication there that the economic incentives in the industry are shifting, and you're aligning your analytic strategy according to value-based care, essentially. At level 7, patient care is informed by analytics at the point of care. Decision support is based on data from social determinants, genomics, and patient activation. That is their willingness and ability to participate in their care. Population-based protocols are customized on a per patient basis at this level. And then finally, at the highest level, analytics and AI tools are available to patients to empower their health decisions. The digital twin and patients like me concept is a core capability, including social networking with similar patients to function as extended members of the care team. All right, friends, now let's ask everyone, where does your organization consistently operate? Is it level 1 and level 2? Is it level 3 and level 4? Level 5, level 6? Or level 7, level 8? And by the way, GoToMeeting has a restriction on these kind of poll questions. Otherwise, we would have been a little more granular. If it will help, I can go back to the previous slide while you contemplate this. Where does your organization consistently operate? Consistently and ubiquitously. Later on, I will also ask in a separate poll, at what level of the model do you occasionally operate as an organization? What's the highest level that you occasionally operate? Okay. And Jordan,
so it looks like, yeah, I just closed it. It looks like 47% are between level 3 and level 4. That was the winner.
Interesting, interesting. So about half at level 3, level 4, yeah. Which that sort of substantiates my hypothesis and one of my assertions going into today's webinar. And I'll come back to that topic here in just a minute. So the motives I had behind publishing this model, the first version of it goes all the way back to probably 1999, but more public versions of it emerged about 10, 15 years ago. So I wanted to share many years of mistakes and successes that I had had prior to coming into healthcare, but then also being one of the early pioneers of analytics and data warehousing in healthcare. I wanted to share some of the mistakes that I made, that we made, that I watched being made, and improve decision-making in healthcare just in general, just as a member of the community and as a patient and a husband and a father. I also wanted it to be used to guide internal development and operational measurement of your own analytics maturity. So to hold this thing up and sort of measure yourself if you're building something internally. If you're not, I wanted it to be used as a framework for evaluating vendors and their solutions. And then finally, it played a significant part in my role at Health Catalyst when I led product and technology. And we lined up our products according to the model and our progression. I've since, stepped down from Health Catalyst. I don't know if it's still used in that context or not. But anyway, those were the motives that I had originally for the model, and I think it still holds up that those are decent use cases and value statements, I hope. I published this paper in 2002. So I had been in healthcare at that point for 5 years, firmly embedded. I'd been dabbling in healthcare for a number of years prior to that, but as an operator in healthcare, I joined Intermountain in '97. And thankfully, Intermountain had enough data uniquely at that time that we had enough data infrastructure there at Intermountain that we could build a data warehouse. So we did. We built a great data warehouse, one of the first in healthcare in '98. And in 2002, I was convinced that these data warehouses and analytics were about to change the industry based on what we had achieved at Intermountain. But now I'm, getting a little grayer. I'm entering my 25th year in healthcare now. And I still sort of feel like we're standing on the brink of a revolution. We're still standing there. We haven't tipped this thing over yet. And I fundamentally believe that one of the primary reasons that we're still standing on the edge instead of tipping over is that our quality measures are holding us back. And to some degree, the poll supported this hypothesis. I think most everyone is stuck at level 3 and 4 of the model because there's a couple of reasons for that. Number one, the quality measures are so complicated. There's so many of them, and they're hard to maintain. So those rare skills that we have amongst data engineers and data analysts are consumed with those lower levels. And the truth is, if you don't deal with level 3 and 4, you're not going to get paid in healthcare. So the economic model is also holding us back. The quality measures and the economic models go hand in hand, right? So economic incentives and quality measures have to be more about outcomes rather than processes of care. And we're burdening our physicians with these quality measures that make no sense at all, right? They're not changing the cost quality curve. So our poor physicians are overwhelmed with collecting data that has no real impact on the industry. And then the other reason is, and I've witnessed this, across the country, especially at Health Catalyst, and now at IMO, is healthcare data quality suffers because the use and the evolution of clinical terminologies is just not working. LOINC, SNOMED, ICD, all of those terminologies have interesting problems. In their context, they're pretty effective. Like ICD is reasonably effective as a World Health Organization international standard for public health reporting, but it's not great for granular capture of clinical intent and clinical precision. SNOMED is interesting academically, but practically it's a very difficult nomenclature to use in a clinical setting. You can do a lot of things with it in a post-coordinated way, in a late binding way, but expecting physicians to navigate through the SNOMED hierarchies is just unrealistic. And I'm not quite sure what's happening with LOINC, but it's not being widely used. And we've seen that as in stark reality in the COVID pandemic, how terribly we've adopted LOINC as a language to describe what's happening with lab results. And so you have to ask yourself why. Why is it that LOINC is not more widely accepted? Is it that there are no economic incentives for it, or is it have something to do with LOINC itself? I actually think it's a little bit of both. I think that LOINC has some problems as a terminology and a vocabulary. I also think it has some problems in that, it's Reagan Street has been managing it, and we thank Reagan Street for what they did with leadership. But the truth is, managing LOINC is probably not core to Reagan Street's economic and career incentives. So I think we've got some things we need to look at nationally around the way our EHR language of healthcare is functioning and make some improvements. This was a report that came out in there it is, May of 2020, from some of the early thought leaders, especially Don Berwick, looking back on the National Quality Forum. And the assessment of these authors' well-informed opinions is that quality measures are not working. And the quotes from this report, I think, are telling. What is primarily missing is not progress in measurement, but progress in results. Therefore, the hope reflected in the founding of NQF that developing, certifying, and using sound metrics of the quality of healthcare would drive fundamental improvement remains largely unrequited. So we have to step back, friends. We've been doing this for a long time. We know that it's not functioning properly. We have to step back and do something about quality measures, because if we do something to improve quality measures, it's going to allow us and give us the time and the expertise to move up the analytic value chain. I asked Ann Phillips, who leads our government affairs and standards office at Intelligent Medical Objects. I said, Ann, what's wrong with quality measures? Give me the message that you'd like me to share with the audience today. And this is what she said. This is exactly the slide that she put together. There are very limited capabilities in the ECQM data model. It supports codified data that describes processes of care, not outcomes of care. It can't be integrated with patient-generated health from surveys and remote monitoring devices. It can't perform complex calculations on clinical observation data. It's not interoperable with clinical decision support. And fundamentally, ECQMs are designed around reimbursement, not quality improvement, process of care, not outcomes of care. And the term that we use quite often in IMO is that we've defaulted to measure what we can in healthcare, not what we need. So it's time for change. It's time for change, friends. This was a report that came out in JAMA, April of 2020, that looked back on the quality measure development and the spending on it. And it was pretty shocking, right? There are nearly 2,300 quality measures in the CMS catalog. 788 of those are implemented and being used. 409 are process measures, 236 are outcomes measures, so that's skewed the wrong direction. And this quote in the lower right also describes the state of affairs, and that is CMS lacks a strategy to evaluate whether their quality measures improve the delivery of care and health outcomes. So there's plenty of evidence that we need to stop and rethink quality measures. My opinion on this, to get to level 5, which is about waste and variability reduction, we should shift our national quality measure strategy to eliminating low value care. There's only 32 in contrast to 2,300. There's only 32 well-defined services that account for more than $300 billion per year in unnecessary care, not to mention the harm and inconvenience to patients. Drilling down even further, only 3 of those clinical services accounted for 67% of the waste: preoperative lab testing, opioids for back pain, and antibiotics for upper respiratory infections. So, if you go back to the analytics adoption model to get above level 3 and 4, where we're trapped in this morass of quality measures, external reporting, simplify that, get a lot of value out of it through the elimination of low value care, reduce the burden on patients and the harm that occurs from unnecessary care, and we can move up the analytics value chain. I would suggest to everyone today, now is the time to opine. We have a new administration and there are new proposals on the table. This is being actively worked right now. By the way, I would say the past administration was actually doing, I think, quite well to address this topic. And so what I'd like to see is continuation of that momentum from the Trump administration in the Biden administration and accelerate that work. So March 2021, Meaningful Measures 2.0, new changes were announced that included the MIPS value pathways. You can see a shift in emphasis on outcomes, population surveillance, public health reporting. In the calendar year 22 proposals, there are 5 new cost measures, 5 new quality measures, 7 new activities focused on health equity. That's all well and good, but we should, for every 5 that we add, we should take 20 off, right? So it's super important that we reduce the number of quality measures rather than continuing to add. Then finally, in 2025, there's an intention to be very FHIR-centric, replacing the HQFM, QDM, and QRDA models. I have some concerns about that, as do Ann, about whether FHIR is actually the right direction or not. But now is the time to comment on this as data professionals, as executives and healthcare friends. If we want to move up the value chain and do more for our patients, now is the time to get involved and offer your opinions to ONC, CMS, FDA, etc. Okay, now I want to put something in the back of your mind here today. I'm going to talk about IMO for just a minute, but I'm not selling IMO because you probably already own it. If you look at the presence of IMO in EHRs, I think you could easily argue that we affect 90% of the clinical encounters in the US. But funny thing is, only about 40% of IMO's clients know that they use the product. It's so firmly embedded seamlessly in the background and somewhat in the foreground of EHR use. So you have this IMO terminology already in your EHR. You're already paying for it. But I guarantee if there's one organization out there that's using IMO terminology in their analytics, I would be surprised. We did when I was at Northwestern, and I was a CIO, Chief Analytics Officer at Northwestern. We pulled the IMO terminology from Epic and Cerner, and we leveraged it in the data warehouse there. But it's not happening now. And I would argue that you ought to be doing this, friends. This is an important part of your data strategy. This slide summarizes how you can maintain the clinical intent that was captured in the EHR downstream in analytics. So over on the left is what the physician enters in the EHR. That is breast cancer metastasized to pelvis. That's the IMO clinically friendly terminology that physicians appreciate and value. And there's an IMO ID associated with that. Underneath that, IMO maps to SNOMED, ICD, et cetera, right? So you see that it's the IMO informatics team stitches together all of these ICDs and SNOMED codes that could be and used to describe breast cancer metastasized to pelvis. But the truth is, individually, none of those terms capture that clinical precision and intent. So we have to put an interface terminology over the top of those. Well, that's great at the EHR, but what happens as you move left to right, in a typical ICD-10 data extraction query, that IMO term gets dropped out. In the upper right corner, you can see there. So typically it's an ICD that gets presented back to the physician and researchers. And you can also see what it does, to the risk score. So your HCC risk score over on the left is 2.6. If you submit that extraction to your billing team, the risk adjustment score is only 0.46. So you're leaving money on the table besides leaving clinical precision back on the table. And so when a physician enters something on the left that looks clinically friendly like that, and they get analytics back on the right that looks like malignant neoplasm of unspecified site of unspecified female breast, I mean, that makes no clinical sense at all, right? What they could get back if we extracted the IMO ID and terminology downstream into the data warehouse, you would get back what the clinician thought they described about the patient. Okay, and again, I'm selling IMO, friends, but I'm not selling it. There's no more money here. This is already something that you're paying for, but not leveraging for the most part. Okay, now let's talk for just a second about why do we even care about analytic maturity? Why should we care? In a classic decision science world, we're trying to ask a few questions, right? At the interpretation, response, and intervention and monitoring and feedback levels. What's going on? What does it mean in the situation? What should we do? How did we do? And how should we adapt? Those are classic lessons from decision science. I was lucky enough to be weaned on these concepts in the military and the decision-making environment that I was trained in. To enable those upper levels of the model, we have to nail the lower two levels here, and that is standardized vocabulary and terminology that makes sense clinically, and then organizing those in value sets standardized by vocabulary and terminology and grouped into meaningful concepts. That's what's holding us back as well, in addition to the quality measures. And COVID, thankfully, put a spotlight on the ineffectiveness of our data and to some degree, the formality of our decision science as well. I would suggest that we've had a hard time answering these basic questions in the COVID world because we didn't have the data to do it. We've always had a hard time with situational awareness, what's going on, what does it mean? We've had a hard time understanding what should we do in response to patients with COVID. And of course, our monitoring and feedback with outcomes has been very hard to measure as well. So ultimately, this is what we're trying to achieve with analytics, I would suggest. And this applies across providers, payers, life sciences, and public health. And the starting point for all of this is the electronic health record. Every one of the downstream secondary users of data in the provider, payer, life sciences, and public health space depend on the quality of the data that we collect in the EHR. And fundamentally, what we're all trying to do is understand that for patients like me, who were treated like this had outcomes like this. It doesn't matter if you're a provider, payer, or life sciences or public health. In one form or another, those are the questions that we're trying to answer. And the data on the right is necessary in order to answer the progressive Venn diagram on the left. And of course, clinician and patient recorded notes are an important part of it. The terminology is critically important, but also the narrative that's captured in a clinical note. So that's why we care about the progression of analytics, friends. It's not to progress up a model, but it's to answer these questions. It's to stitch together these patterns that benefit each of us and our families. Okay, let's dive into the model a little bit more here. The first time I really published this on a widespread basis outside of the advisory board was in a Canadian-based journal called Electronic Healthcare, where I worked on this with Dennis Praddy at the University of British Columbia. And we called it a model for measuring industry-wide adoption and capability of healthcare analytics. And those were the levels that we had at that time. Pretty significant evolution of the model since then. In 2015, HIMSS adopted the model, and we worked collaboratively. I said, you can have it. I have no interest in making money off the model. All I want to do is help the industry. And so I wanted HIMSS to take this out to the world like they did the EMR adoption model and hopefully progress the industry and provide some incentives for going up the model. So they now go out and they audit and they can provide guidance on how to get to level 6 and 7 in the model. It's been very effective. Although I would say it hasn't caught on like the EMR adoption model did. The EMR adoption model became kind of a laurel of achievement for digital health. And when high-tech money was going around and it was kind of cool to deploy EHRs, it drove a lot of interest in the EMR adoption model and wearing that crown of achievement for level 7. For whatever reason, that same sort of excitement around analytics has not caught on. And but there are some notable hospitals here that have achieved level 6 or 7. So there's a few. I think there are 40 names here. In comparison, I think there are maybe 100 to 120 organizations that have achieved level 7 on the EMR adoption model. As I look at this, there are several hospitals in the Intermountain network that have achieved level 7 based on the old data warehouse we built way back in 1997, 98. So anyway, there's some momentum, but I'd like to see more. I think we all should want to see more. And maybe now that that we're kind of taking a breath from recovering and going through COVID, maybe there'll be an opportunity to do that. Okay, back to the model again here, friend, for just a minute. Here it is, just one more time, taking a look at it now that we've gone high and low on the concepts. Okay, just a refresher. I would say, if we shift our quality measures, I think it's going to free up all the work that we currently consume in level 3 and 4 and allow us to move up and address level 5, right? Because now our external reporting naturally supports waste and care variability reduction through low value care if we're reimbursed according to low value care. The truth is, to get to level 6, we really have to move into value-based contracting. So it's not enough to change our quality measures. That's a start. If we shifted to low value care, that would help us get to level 5. But the truth is, until we get to value-based care, where risk mitigation and intervention really pay off, where health pays off as opposed to disease, I don't think we'll get above level 6 and 7. I do think that we can start providing level 8 direct to patient analytics right now. We can do it right now. We should be doing it right now. We should have data about patients, de-identified data about patients like me, available for our patients to browse on our healthcare system websites so they can understand what kind of treatments other patients are receiving, who's treating those patients, who sees the most volume, And then ideally, we would give patients the opportunity to reach out anonymously and network with other patients like them and bring them into their care environment. So I actually think that you could, in the absence of progression on value-based care that would drive level 6 and level 7, I think you could actually jump from level 5 to level 8 without dramatic changes to the economic incentives in healthcare. All right, there's some thoughts. Keep that in the back of your mind. Now, we've gone back to that. Ask yourselves, what's the highest level of the model that your organization occasionally operates? Okay, what's the highest level of the model? I bet it's higher than level 1 and level 2. We certainly saw level 3 and level 4 is pretty significant. And during the Q&A, if there are any organizations that are consistently operating and providing data to level 8 direct to patients, I would just love to hear those case stories and share that with the audience. Okay, numbers are churning here. Jordan, when you see it level off, I'll turn to you, friend.
It looks like 41% said level 5 to level 6.
Interesting.
That was the...
Yeah, that's cool. That's very interesting data. And there's some folks at level 7 and level 8, right, that are occasionally operating at that level. So we'd love to hear those stories. But those are encouraging numbers, right? Those are, in mountain climbing parlance, those are toeholds and footholds, right? We can climb from there. That's awesome. That's encouraging. Okay, let's go to the next poll question here. So now you've had some time to think about it, and I've tried to justify my case just a little bit. By the way, I don't want to bias the jury here. I want you to give me the honest truth, because if I'm asserting a hypothesis that has no basis, then I want to know about it. So to what degree do you agree that our country's current clinical quality measure strategy is holding us back from progressing to the higher value analytics and AI? Strongly disagree, somewhat disagree, neutral, no opinion, somewhat agree, strongly agree. Well, it'd be fun to, we'll publish these poll results out on social media too, friends, so that you can share it around with your teams and maybe generate some interest in your executive teams and things like that around changing quality measures or supporting the progression of analytics in your organization. How are we doing there, Jordan?
So it looks like about 50% said somewhat agree.
Okay. Got it. Thank you. Pretty interesting. So between, I'm looking at the numbers, 48% somewhat agree, 33%. So that's what, 81%. 81% agree either strongly or somewhat that quality measures are holding us back. That's a pretty substantial opinion, isn't it? Okay. That'll be fun. We'll do something with that data and take it forward to other audiences. All right, let's go on to the next slide here. So now let's fly through the details, friends. And the truth is, I give classes, multi-day classes, like 3-4 hours on the details in this model. So we're not going to be able to go into all the details, but I will say that I'm happy to have more intimate discussions with you and your organizations about how to progress through these levels. And also, I really would appreciate feedback about how to improve the details in each level of the model, because what I try to do in the details of each model is describe the 4 parts of each level that you need to address. So each level of the model requires changes to and progression in the 4 areas you see here. Data and analytics competency, that is the skills to leverage and utilize the data. Infrastructure, you have to evolve your basic compute, storage, network, system management, data pipelines, end user tools. You have to evolve your data and analytics governance, and it gets progressively complicated as you move up the model. And it includes more than just data, it includes algorithms. And then you're constantly adding and refreshing and managing content, addressing quality, timeliness, completeness, validity, and accessibility. Okay, those are the 4 sub-themes in each level. Now let's kind of fly through some of these. And again, there's way more here than we can cover in the time that we have today, but we'll try to summarize some of it. I think we know what a fragmented data environment looks like. So this just describes the situation. It's not so much what you should do, but what you shouldn't be doing. I don't think there's any need to spend much time there. At level 1, now you've committed as an organization to build out an enterprise data warehouse, or as we called it at Health Catalyst, enterprise data operating system. And that includes the development of analytics competency and data literacy in the organization. So it makes no sense to build the infrastructure of an EDW if you don't also build the skills. I have a saying in life: mindset, skill set, tool set, in that order. And if you move too far ahead with tool set without addressing mindset and skill set, you're going to end up with a dust collector for an asset. So the infrastructure, now the good news is you're building out infrastructure in the cloud, I hope, which significantly lowers the barrier of entry into enterprise data warehousing. It's like, it's actually now, even though it's easier to deploy a data warehouse than it ever has been technically, there are so many options, it becomes confusing which is the best to choose. But that's a good problem to have. So now you're beginning to create data governance. You've got organizational commitment around the notion of a data warehouse. You're lining up data stewardship. I advocate, in the lower left, you'll see, I always advocate that the data warehouse initially reports to the CIO, because for the most part, you're building out infrastructure here. And it assumes that the CIO can facilitate access to and the extraction of data from source systems. But generally speaking, I also advocate that over time, that the EDW, the data warehouse, the data lake, shift in its reporting towards the chief medical officer, the chief analytics officer, but someone other than the CIO. Now, sometimes the CIO can wear that hat as well. It usually requires a different kind of CIO than what we typically had in healthcare. But for sure, I advocate that it begin with a reporting structure to the CIO, because building out the infrastructure is essentially a technical undertaking, and providing access to those source systems is super important. And usually the CIO is the best person to do that. And then as a minimum, your data content has to contain, HIMSS, EMR, stage 3 clinical data. That is stage 3 adoption. If you have greater value, higher level data in your EMR, you certainly want to bring that in. You want to bring in financial data, especially costing data. You want materials and supply chain data. You want patient experience data, and you want claims if it's available. That's laying down the basic foundation of data content that all sorts of use cases will benefit from. Okay, that's basic data content at the infrastructure level. Now you've got data content, you've got to lay standardized vocabulary and patient registries on top of that. And you've got to go back to the source systems to encourage the standard use of vocabulary. So now you're laying vocabulary on top of the content at the source system, as well as a normalization strategy in the data warehouse. And you're also starting to build out patient registries, because going back to the Venn diagram, patients like this, patients like me, that's the beginning use case for virtually every meaningful analytics, higher level analytics use case in healthcare. It's the beginning of the patient identity and the patient type that matters most. So super important that you start building out patient registries at level 2, because everything you do of any significance is going to be based around a patient type. Master vocabularies and reference data are super important at this level, and standardizing according to local reference data is a part of this, going back to the source systems. Your governance function starts to evolve, including who owns master data. The ownership of the patient registries is super important. Like, who's going to define the algorithms and the definitions of patient registries? Super important there. And by the way, you'll want to have the ability to manage multiple definitions of what seems to be synonymous patient types. There are lots of definitions for a diabetic patient in the industry. There are lots of definitions for a hypertensive patient. And so you'll want a governance structure that acknowledges the reality of those synonymous definitions and the ability for technically distinguishing between those two in the data and in the data warehouse. Okay? Super important to have master patient identity, physician identity, procedure codes, diagnosis codes, facility codes, department codes, gender. Now SDOH is a core part of that. That's probably something I need to include here. And then your patient registries at this level are probably around billing codes and defined by multidisciplinary teams. I mean, billing codes are probably sufficient at this point because you're going to be billing those mostly for reimbursement and public health reporting. But that won't be good enough for long. All right, now we're moving up to level 3. And at level 3 now, your competency is shifting towards the automated production and stewardship of internal reporting so that every month and every quarter that's consistent. You're not going through a fire drill every month and every quarter to produce these internal reports. You're giving the executives and the boards the data they need. You're providing a level of self-service analytics and KPIs for VPs, directors, and managers. Reports are available, consistent, and accurate. And you don't want to proliferate too many reports in this space either, right? Stewardship of the reports is super important. The infrastructure is capable at this level of supporting a broad case of users, hundreds of users, hopefully thousands of users a day in the organization. The data and analytics governance function, you know, you're starting to collaborate between corporate and business unit analysts. So you've got central data analysts and data engineers, but you've got distributed data engineers and data analysts leveraging the infrastructure. But you bring those two groups together, the corporate folks, the business unit folks, as data professionals, you bring them together and they're collaborating together towards the evolution of the infrastructure and also the most efficient production and reducing redundancy of reporting. There's a lot of emphasis now being placed on data quality assurance and data literacy training at this level. This is the beginning of widespread use of data in the organization. Super important that data quality be communicated and measured. And what you're trying to get to is little or no labor to maintain these reports. Okay? Your data content now is characterized by a wide-reaching database schema. So this is when you get away from late binding. Now you're getting towards standardized data models because you have to have standardized data models to support standardized reporting. So late binding starts to fade away in this level. And you have to bring clinical, financial, and operational data together. So this is one of the good things about FHIR, for example, is a reference schema. It's starting to address these broader data model issues and requirements. The USDDI coming out of ONC is also a broader view of data. OMOP in the life sciences world is an additional data schema that you should have in your data warehouse. And the interesting thing is we're seeing that FHIR and OMOP are coming together. So super important that you have standard industry supported schemas beginning to emerge at this level. It's super important to scalability. At level 4, now we're focusing on automated external reporting. So same kind of concepts, but now we're looking externally and we're trying to manage and keep track of value sets essentially that are driving us towards regulatory accreditation, compliance, all those external bodies we have to report to, the funding and payer requirements, commercial incentives, you know, meaningful use. I should probably update that, shouldn't I? And then specialty society databases. Those are really the 3 categories of value sets that you should have, along with the supporting schemas and the supporting vocabulary for each of those 3 categories. So regulatory and accreditation, funding and payer requirements, how you're getting paid, and then specialty society databases. You should have standardized data models, standardized vocabularies, standardized and regulated analytic logic that wraps all around those. You want to apply software engineering concepts around reuse and inheritance to data engineering at this level. Okay. Now in the infrastructure, you're starting to broaden your compliance with vocabularies. You're moving into full compliance with international and national standards, ICD, CPD, SNOMED, ARCS, NORM, LOINC, and others. I would also mention, friends, that you already own IMO. IMO makes the management of this vocabulary world much easier because the IMO vocabulary team is allowing the SNOMED, ICD, CPT, et cetera, that evolves underneath the clinical terms that the IMO team defines. So it abstracts you from the complexity of churn that occurs around annual and more often changes in these national standards. The IMO vocabulary team is managing those changes for you at that level. And again, you're already paying for this. The EDW is engineered for agility to respond to the constantly changing nature of external reporting. So now you're starting to look at things like microservices, right? Software engineering applied to data. And you have the ability to do basic, simple keyword searches across patient records at this point. Because, as indicated in the lower right, now you're starting to pull text data into your data content strategy. So you've moved beyond categorical data. Now you've moved into bringing in text data to this, okay? And of course, your data and analytics governance has to progress as well. Clear ownership of who owns the definitions and the quality strategy for external reporting. Who are the stewards, not just at the data level, but at the reporting level is very important in this level. Now at level 5, we're moving into waste and care variability reduction. This is where we have a challenge right now, friends, because we get paid for waste and care variability right now in the current economic model of healthcare. We get paid for this. That's unfortunate. In a fee-for-service world, there's really no incentive to reduce waste. There's no incentive to reduce unnecessary orders, unnecessary labs, unnecessary meds and procedures. If we shift our quality measures, of course, that changes it, right? So hopefully we can do that. You're using data at this level to differentiate the market or differentiate yourself in the market now. This is, everything below this is kind of commodity analytics. But at this level, you're really starting to differentiate yourself around quality of care and patient convenience. And also, I would suggest physician satisfaction starts to emerge at this level as well. Now you're delivering analytics that really helps inform the organization to be better in the eyes of its stakeholders. Okay, you've got evidence-based standardized data marts, reusable data marts that combine clinical and cost data with patient registries. So you have a robust infrastructure for identifying patients like this, patients like me. Now you're expanding to say who were treated like this. You're starting to understand that world better with the data that you have. And then you're finally moving into getting ready for outcomes related understanding. Patients like this who were treated like this had outcomes like this. You're preparing yourself for population-based analytics here. So in addition to the core data content mentioned earlier on, you've got granular data from the labs, pharmacy, and clinical observations in your patient cohort. Okay, so you're rounding out your patient cohort identity here. And you're actively going after insurance claims and HIE data feeds. Okay, by the way, some people might say, well, we're already pulling in lab, pharmacy, et cetera, from the EHR. No, that's really probably not true. There's a lot of very granular data in those pharmacy systems and lab systems that don't get brought into the EHR that you'll want for more specific analytics and process improvement in those verticals. Okay. Now at level 6, we're moving into population health and predictive analytics. You've got a sustainable, very literate culture. Got a misspelling there. You have a firm analytic environment for understanding clinical outcomes. So now you're collecting patient activation measures and things like that. The financial model rewards risk mitigation. And I've made, the competency here is tied to bundled payments. I may have to change that. I don't know if we're ever going to get there on that. But analytics is available now at the point of care to support the triple aim. So now you're closing the loop from what I call conference room analytics, and you're packaging that back up and using APIs to support analytics and decision support and guidance to physicians at the point of care. The truth is that's not easy to do yet technically with our current EHRs, but it's getting better. So at this level, it's super important that you start thinking about how we close the loop of analytics and decision support from the data warehouse back into the electronic health record. And now also the infrastructure requires more frequent updates. The truth is you should engineer your data warehouse from the very beginnings for near real-time updates. So these slides need to be updated a little bit. The bottom line is you want to move from less frequent updates of your data content to near real-time updates if you haven't done it already. In the data and analytics governance space, there's a major role in the accuracy of metrics. So now data governance is really starting to focus on algorithms and reporting as much as it is data content. And the EDW team now probably should shift its reporting structure over to a C-level executive that's accountable for balancing cost and quality of care. If you think about it right now, it's pretty common for the CFO in a healthcare system to own cost of care sometimes, and the CMO to own quality of care. But the truth is, the value equation in healthcare is a combination of cost and quality. So hopefully at some point in the future, we'll see a single person in the healthcare system executive team owning this balance between cost of care and quality of care. And now at this point, your data content includes data from bedside devices, home monitoring data, external pharmacies, and hopefully you've moved towards activity-based costing. So you've built out transaction systems in the meantime that will support detailed activity-based costing to support level 6. Because cost of care is super important in value-based care, right? You have to understand your cost of care as it relates to margins on a per capita basis for patient management. All right, now we're getting into level 7, and this one gets really wordy, but it's personalized medicine and prescriptive analytics. Now we're moving to very precise patient-tailored care. We're becoming a learning health system really at this level. Patient employer fixed fee per capita payments are common in the industry. That's driving your analytics strategy. Let's hope, right? Let's drive the economic incentives along with the analytic progression. Consumers have an unprecedented capacity to take charge. Now it's in their DNA, their cell phones, their individual information. So you're preparing consumers and patients to take greater role in their data-informed decision-making. And the new data content in the EDW is now combined with algorithms we haven't even discovered yet, and the relationships between genomics, family history, and patient environment, the social determinants. And the EDW is essentially real time at this point. The data content includes natural language processing on text. Prescriptive analytics is part of the algorithmic environment. And now you're moving towards interventional decision support for clinicians and care management teams. And you've got 7x24 biometrics data here, genomic data and familial data as a part of your data content. And then finally, this is my goal in life, is that we have some kind of an avatar that provides direct-to-patient analytics and AI. And I can imagine having a conversation with an avatar at some point that says, "Hi, Dale, thanks for your data. I'm calculating a health optimization recommendation for you, informed not only by the latest clinical trials, but also by local and regional data about patients like you, the real-world health outcomes over time of every patient like you, and the level of your interest and ability to engage in your own care. With all of that data, I will tell you within a specified range of confidence which treatment or health management plan is best suited for a patient specifically like you and how much that will cost. All right, there you go. That's the level 8 goal there, friends. Thanks for hanging with me. I think now we're ready for Q&A. We've got 5 minutes. I can stay over if any of the audience members are interested in staying over. But I'll turn it back over to you, Jordan, and we'll go to Q&A. I guess, let's see, looks like I can pull up the Q&A. Is that right?
Yep, there's a few questions in there.
Okay. For some reason, my mouse is not working with GoToMeeting in presentation mode, so I'm gonna have to get rid of that. Okay, let's see here. We've got a few questions. Will this deck? Yes, the deck will be available. I think, Jordan, you're going to record the audio too. Is that right?
Yep. So it will be given to everyone after the webinar, so later this week. Okay.
Mark Lever asks, my question is outside of CQM, compliance regulatory. What is the biggest challenge to analytics innovation by healthcare organizations? Well, I think the biggest challenge, Mark, is that the economic incentives in healthcare right now just don't really incentivize precise analytics. I think if the economics were more aligned around, precision in healthcare, precision decision making, reduction of waste, reduction of patient safety events, I think we'd see greater money and attention being paid on analytics than what we have right now. So I fundamentally believe that it's the economic incentives that are holding back the progressive use of analytics. I'm super grateful to hear that there are a number of organizations that are operating, up around level 7 and 8 of the model, at least occasionally. So despite the fact that we don't have much in the way of economic incentives, people are doing it anyway, organizations are doing it anyway, and I think that's how you define leadership. Also, I think it's, whether the economics ever change or not, the truth of the matter is the data that's coming out of our EHRs is really low quality. And that's not a reflection on the EHRs or the physicians. It's a reflection on the fact that we've only standardized our vocabularies for reimbursement incentives. So for instance, looking across these national data sets that I've been exposed to the last few years, on average, about 20% of lab orders and results are normalized to LOINC. And you can see that those orders that are normalized are typically affiliated with some sort of quality measure. And so there's reimbursements associated with it. But we have to standardize our order catalogs on our orderables in order to progress up the analytics value chain, because without that standardized vocabulary, the quality of analytics will suffer, and our data engineers and our data analysts will be caught in this constant cycle of trying to clean up and normalize data that should be normalized at the point of care. Thanks, Mark. And there's Beckett Monkey, one of my favorite friends and amazing CMIOs. And Beckett asks, no doubt that process measures are inherently not satisfying, but they do have an actionable time horizon, about 1 year max. We would prefer outcome measures, but many, yeah, this is a good point. I see where you're going here, Beckett. We would prefer outcome measures, but many have time horizons measured in decades, which makes selecting outcome measures difficult for various reasons, reimbursement, human behavior change. Yeah, I do agree with that. So how do we strike a balance to realistically move? I totally agree, friend, that those time horizons for outcomes can be very long, but I think if we did nothing else, and STARS is sort of trying to do this, we can ask simple questions like my Volvo dealer asks, which is, they ask outcomes questions like, I may take the car in for him to fix a problem. It might take me 1,000 miles of driving that car to really trust that he fixed the problem. But the experience that I had is an indication of quality of care. So I think doing a better job with experience measures is the beginnings of an understanding of our outcomes environment. But typically we need to spend more time on what it means to be satisfied as a patient. But I don't see us typically associating with treatment protocols and outcomes. It's more about the relationship with the physician and the experience, which is okay. That's a beginning of, patient satisfaction is the beginning of the outcomes journey, while we develop sort of stepwise measures around outcomes that recognizes, it's hard to understand whether a treatment protocol is working for a diabetic when, diabetes progresses at such a slow pace. We won't know for 10, 15 years whether those treatment protocols are effective. But I don't think we can relax on this progression towards outcomes measures and getting away from process measures. And if we're going to fall towards process measures, then let's focus on low value processes, right? Let's focus on those things that we know we shouldn't be doing in the process of care, rather than the 2,300, the 800, the 500 process of care measures that we have right now. Thanks, Beckett. Love to chat with you more about all that. Dan Reber asks, thoughts on all the buzzword noise that many analytics vendors use. Does it make progression up the levels harder? Well, that's a good question, Dan. I mean, noisy data. Well, let me back up. In the space and defense world, you work with noisy data all the time. You just accept the fact that you're going to deal with noisy, anomalous data. And so from a pure data science perspective, you just take that for what it is. You're going to get spurious data, you're going to get noisy data, and you deal with it in your models. But what I don't see much evidence of in healthcare yet is data science, and certainly declarative analytics, that formally recognizes the noise and the anomalies in data that we have right now. I don't see any significant vendors putting forth a good strategy for analytics that recognizes the anomalies, the need for anomaly detection in clinical data right now. So I do hear vendors talking about noise in data, but what I don't see is typical data science, machine learning concepts that have been around for decades, especially in the space and defense world, that recognize that there will always be noise in data. And if you don't study that noise and identify it with anomaly detection, it's going to influence the way you look at the data in a negative way. So the good news is, Dan, I guess there's talk about noise in data right now. What I don't see amongst analytic vendors is a traditional data science approach to treating anomalous content. There you go. What do you think, Jordan? Should we wrap it up, friends? There's no more questions.
Yeah, I think.
Yeah,
now's the perfect opportunity.
Is that good? Okay, and we can. I'm super interested to capture those poll questions and share those socially and with the audience. So that would be great too. Yes, for sure. All right, so we're going to go ahead and close out today. We hope you found Dale's presentation useful and helpful and informative. If you want any more information about IMO, please contact your IMO client executive at sales@imohealth.com. The recording will be made available, like we mentioned earlier. I hope everyone has a safe and healthy rest of your week. Thank you. Thanks, everybody. Have a great day.